The fourth category of issues we defined as political issues. You can see there was one big sub-theme here. So of the 18 responses in this category, 13 were classed as external pressures on health technology assessment agencies. These were predominantly from two locations. So there was policy pressure on the healthcare system, and in many countries the HTA organisation is part of the healthcare system. There was policy pressure to act quickly, to do something quickly and get on top of this healthcare issue. And that the risk there is the risk of acting quickly and under pressure is that you become more likely to divert from your usual robust processes and ultimately make the wrong decision. You accept lower quality evidence, you don't undertake the kind of level of robust scrutiny of the evidence that you normally would. Something has to give if you need to act quicker. And the risk there is that you ultimately make a decision that's wrong, gets proven to be wrong, in that the treatment that you say, yes, reimburse this treatment, it's effective and it's probably cost effective. Actually, when a bit more evidence comes out, it appears that it wasn't effective and a lot of money has been wasted using it. There was a societal pressure as well, so from citizens, from the media, from the public at large, that treatments were needed. You know, nobody liked what was happening. The societal, the lockdowns, and all how it dramatically affected society, and there was a real appetite to get on top of it with effective treatments, and you know, fix the situation. So that's more extensive public scrutiny than HTA agencies are usually used to. And again, the issue there is the same, that if there's a societal pressure to approve treatments, if you then as an agency approve a treatment or recommend that a treatment is reimbursed that you otherwise wouldn't have without that pressure, then there's a higher risk of that decision actually being incorrect and negative to the health system in the light of day later down the line. So we're very used to, as a HTA body, having our decisions consulted on and scrutinised, but usually by quite narrow stakeholder groups of a defined patient population of interest, a defined stakeholder group of companies in this working in a particular area, whereas instead everybody in society, all citizens, were potentially affected by COVID-19. And so that constituency of people that were interested in what the health system was doing and what HTA bodies and organisations might say about COVID-19 treatments was a lot bigger than usual. And that public scrutiny of decisions and processes was just difficult to deal with and not something we're used to, and just changed the context in which we were trying to work. There were two smaller issues that we've categorised as political. One is supply issues. So we saw with vaccines that there was a limited global supply of many of the most commonly used vaccines, and that there were some shortages at different times during the pandemic. And there was a fear that that would also be the case with effective treatments. If it got identified that a treatment was really effective, would the manufacturer of that treatment have the capacity to meet global demand? I've talked before about how a robust assessment process, HTA process, takes time to review the evidence, scrutinise it, understand the effectiveness, cost effectiveness. If you, as an HTA agency, stick to your potentially slow and rigid processes, take your time to make a decision, and then at the end of that process say, yes, this treatment is cost effective, go ahead and use it, help payer, that might be too far down the line. The global supply, that might put us to the back of the queue, and the global supply of that limited resource might already be allocated to other countries. And because you undertook your robust, long process, you've missed out on an effective treatment. So that was an interesting and unusual context. The other was there were some prominent ethical issues, a few of which were raised. So I guess the obvious one is The result of a health technology assessment could be that no, this treatment should not be used, even if it's effective. The price is too high, it's not cost effective, don't use it. Or the process, that robust process can itself take time and delay access to effective treatments. So that's potentially unethical given the urgent situation, the healthcare emergency. And also there was an interesting response that of that limited global supply potentially being channeled to high-income countries. Most high-income countries have more established HTA processes that are perhaps more agile to help their healthcare systems and payers think about pricing and think about, somehow help this situation. And that was seen as a potential ethical issue, not something that an individual health technology assessment organization will perhaps be too worried about for their internal healthcare system, but that's just an extra kind of wider pressure that we were working in. Excuse me. Lastly, the fifth theme that we pulled out related to practical issues. Now, these were more about ways of working during the pandemic. We were all affected professionally by how we could work during 2020 and 2021. And the issues in this category were around that. So how did HTA working practices have to change or evolve during the pandemic? And these are not necessarily specific to assessing COVID technologies, but how that affected what we do. The biggest sub-theme related to issues of workload and capacity. So, as we saw in the previous section, there was a policy and kind of societal and healthcare need to act quickly. We were trying to marry that with acting quickly and doing something useful, quickly producing recommendations and guidance with a really rapidly evolving evidence base, an evolving disease, changing pandemic context with waves of new infections and new variants. So it's hard to do your job quickly in this really uncertain COVID-19 context. And both of those things require a lot of resource. So you need people in the HTA organization to try and keep on top of the change in evidence. And you need people to perhaps drop what they're doing on, assessments and other diseases to focus on producing outputs related to COVID-19 as quickly as possible. So there was a twofold issue here of it's really hard to do something rapid for COVID-19 with limited capacity. And also there's a knock-on effect of you're slowing down on some other things. So all the non-COVID conditions and treatments for those conditions, potentially new effective treatments, we were slower. Well, the HTA community would have been slower to get out recommendations for those things and assess those treatments because of the need to focus on COVID-19. Some comments received talked about the future implications of COVID-19 on their working practices. So again, this is a copy from the previous point, but the need to keep on top of the evolving evidence base and clinical situation and scientific understanding. Linked to that is if you've made a decision at a point in time, but you know that the disease is changing and you know that the vaccination status of the population is changing, the whole context is changing, new studies are being reported very quickly, then what does that mean for you as a HTA organization in terms of how often you need to review the evidence and review your decisions and go back and think, well, that decision we made 6 months ago is now not appropriate, so let's take that away. And what does that mean for the health system? Is it useful to the health system if their HTA organization every 6 months, every year is changing decisions and saying, well, this treatment that we said was good is now not good, so stop using it? How implementable is that for a health system? How useful is that constantly? That's a kind of living way of assessments. So yeah, a living HTA or a rolling HTA. A few agencies that we spoke to had used COVID as an opportunity to test this. So can we keep on top of the evidence and keep changing our recommendations as we learn more and as more clinical evidence becomes available? So some agencies did pilot that, and I think Ireland and Canada in particular, the agencies there are prominent in that. But that poses challenges. That's not our usual way of working. The last sub-theme related to practical issues around stakeholder engagement. So for COVID-19, particularly in the early part of 21, 22, there was no established patient organisation. So it was difficult to identify patient groups to engage with in our assessments. Whereas we would usually, there are usually established patient organisations, patient representatives and advocacy groups for different conditions. That wasn't really the case for COVID-19. And like I mentioned before, everyone was potentially affected by COVID-19. So there's perhaps an increasing need to engage with citizens, the general population, in addition to specific COVID-19 patients. That's perhaps not typical of our assessments. We were also faced with an issue of for our assessments in COVID-19 and in all conditions, we request input from practicing clinicians in the relevant disease area. Now, during the pandemic in 2021 and 22, it would not have been very helpful or nice as an agency to call upon respiratory medicine consultants to take a day off work and come to NICE and help us look at the evidence, because they were needed. They were, hospitals were at capacity, and it's been very well documented how overworked many clinicians were. So it was difficult for us to engage with healthcare professionals in a meaningful way and not divert their resources away from dealing with the situation. It was also difficult to engage generally. So how do we speak with people? We historically held committee decision-making meetings in a big room on a U-shaped table where we could all talk, and that obviously had to stop. So we quickly had to move to a different way of working, a remote way of working, which was a challenge. It was very, very different to what we were used to. And other agencies that we spoke to saw other ways to engage with clinicians and patients, perhaps like using micro websites and electronic ways of engaging. But these were all thrust upon us. We didn't want to stop what we were doing. We didn't want to reduce stakeholder engagement. It's a crucial part of HTA. But how we did that had to quickly change. Francois, did you have a question?
It's a broader comment, but maybe you first want to conclude and...
Sure. So that concludes the kind of 5 key themes of challenges that we heard from health technology assessment agencies in 2021 when it came to assessing technologies for COVID-19. And they were perceived, we heard that those challenges were perceived, it was believed that they would be present for at least a year or two as the clinical evidence base develops, vaccinations take effect, before things settle down, essentially. We're now in 2023, so that work is 2 years old. And it's perhaps a really good point to do something that we haven't done yet and think about, are the challenges we heard still relevant today? So it's my view that many of them are still relevant, not necessarily in the context of assessing COVID-19 technologies, because that disease situation has settled down to a degree with the uptake of vaccinations. But it put many challenges that we face in other assessments that we do day to day in the spotlight all at once, all together. So things like, how can we use non-randomized data for reimbursement decisions. You don't have a randomized trial, but you still have to make a decision. The regulator's happy with it. What do you do as a HTA agency to make a reimbursement decision? We were faced with that situation with COVID-19, and we will continue to be with many other treatments. What do we do when there's no long-term evidence? How comfortable are we extrapolating into the future based on short-term data? Can we do our assessments faster? And are we engaging with stakeholders in the most efficient way, the best way? These are all questions that I think really quickly we had to kind of take a view on during COVID-19, and the learnings from that will be taken forward and are relevant to many disease areas. I think the pandemic was actually a catalyst for change, positive change in many of these areas. So just picking one out, so from the perspective of NICE, we've now implemented a proportionate approach to technology appraisals, which means doing our assessments faster where it's appropriate to do so. We've published a real-world evidence framework on what we want to see from real-world data to use it in decision-making. And our committee meetings, our decision-making committees with clinicians, patients, companies, all the relevant stakeholders are now permanently hybrid, so that works a lot better. That's much more accessible for many stakeholders. So it was definitely a catalyst for some improvements in these areas. Some of the challenges remain relevant. I think crucially among them is, I mentioned this before, what does the HTA community and what do organisations like NICE do the next time a healthcare emergency or an infectious disease pandemic happens? Can there be some kind of pandemic preparedness plan put in place for us to very quickly provide meaningful help to payers and healthcare systems away from our usual more rigid and perhaps slower processes? I think that's some thinking that many agencies will be doing, and I hope that when the time comes, the HTA community is in a much stronger position to help.
Well, many thanks for this detailed explanation of the challenges. I think, but maybe I'm wrong, that there were also facilitators during this period. And the perception we have is, for example, when HTA bodies were asking additional questions to industry would be very reactive when they had the response to the question. Or also in hospitals, the creation of many databases and real-world data sources which did not exist before, which could be used maybe during your assessment as another facilitator of the assessment of the technologies. I think these were real innovative approaches during the pandemic. And regarding your comment on how to be prepared, I'm speaking here as former member of the EMA Emergency Task Force, where in addition to providing scientific advice to developers of technologies for these emergencies, another duty is to brainstorm on how to have our countries better prepared for the next pandemic. And that's exactly what you're mentioning here. And maybe this is something we should push for, to have the equivalent of this emergency task force within several HTA bodies to discuss from these challenges that we know are important, how to be prepared, better prepared for the next time. Not one agency will succeed. I think it has to be a collaborative effort at the European level. And regarding stakeholder engagement in particular, it's clear that for COVID, at all decision-making levels, this has not been done in a satisfying manner. Even the decisions for the triage of patients in ICU or clinical trials, most of which were designed to fail anyway, being mono-country or not enough patients or poorly designed. with no capacity, no room to discuss these clinical trials with representative of the citizens or patients. So that's something that is also urgently needed, to think of stakeholder involvement procedure in situations of emergencies where certainly we don't want to slow down the decision making, but we have to create and to organize the dialogue in a way that is really timely and effective. But that's we don't have the solutions yet, but I think that's two ways, two directions where we need to reinforce the dialogue, the discussion. And maybe in the next presentation, because another important exercise you conducted was the COVID-19 policy sandbox, where you explained, well, I think the starting point was that different HTA bodies were using different endpoints to assess the same technologies. And I understand that with this sandbox, you could propose a more harmonized way to conduct this assessment. And do you think this is something you could also explain in a next video, or?
Yeah, happy to do that.
We don't want to take too much of your time, but
yeah, I mean that was fairly recently published, so it's probably a nice time to do that. Yeah.
Okay.
And now I have two questions. At the time where the survey was conducted and when the COVID-19 pandemic was happening, we did not have the new HTA regulation. Do you think that now that we have the new HTA regulation, that it could help address some of these issues in times of crisis? And if yes, how so? And my second question is about, so I remember there were 3 countries from Central and Eastern Europe. Do you recall any striking difference between Western countries that have replied to the survey and those Central and Eastern Europe countries?
So to your first point on the joint clinical assessment, the HTA regulation, I think that can only be a positive thing, in that when this pandemic hit, and this possibly speaks to Francois' point slightly before as well, there was lots happening and it was quite chaotic, and there were things happening in different countries, different hospitals, and it was kind of up to individual HTA agencies and healthcare systems to kind of find their way through that. So I think anything that enforces some collaboration will be helpful. It will also lead to hopefully quicker and more consistent evidence being produced, because the companies that repurpose their medicines and try quickly try to develop evidence to deal with whatever that emergency looks like will have a bit more consistency of, okay, there's a large constituency of European countries here that have this unified process, and we know what they want as a group, and that can only help speed things along from their side, rather than having to deal with disparate healthcare systems that require slightly different things. And in regards to your second question, could you remind me of that, please?
I was just wondering, since there were 3 countries from Central and Eastern Europe, if there were any striking difference between Western Europe and Central and Eastern Europe, or even between countries, if you recall anything that struck you in the answers.
Only that. Nothing strikingly different between the Western and Central and Eastern European cohorts. I think I recall that the representatives from Central and Eastern Europe were quite vocal about the need for cross-border collaboration in response to healthcare emergencies and pandemics. I think also a prominent split was countries where their health technology assessment organisations already use or are happy to see more societal analyses, societal perspectives taken, were more vocal about that being the appropriate thing to do in the disease pandemic, which is, it's a challenging question for an agency like NICE or in a jurisdiction where the perspective is almost always a healthcare one, because that would be a big shift, a big change for us and similar organisations. So that's something that needs a lot of thought if that going forward. But there was definitely a bit of a split there in that countries that already take a societal or at least a partly societal view were strongly of the view that you definitely should in a pandemic.
Thank you very much.